Right. So the first case we are going to present is of a 56-year-old gentleman who is right-handed with current KPS of 90. He presented to us in at AQH with history of headache and vomiting for last 1 week. We got an MRI brain done, which shows a right temporal lesion. So the images in front of us on my left-hand side are the T1 pre, while on the right-hand side are T1 post-contrast images.
So, Zena, we do have Dr. Shayan and Dr. Shumaila with us, so we can have their opinion also. So, Dr. Shumaila, should I go through all the images and then you'll tell your...
No, I think I will go slide by slide.
Okay.
So here we have on the left hand side, we have pre-contrast images, and on the right hand side, we have post-gadolinium images. And we can appreciate that there is a hypo-intense area in the right temporal lobe, which is showing some peripheral thick enhancing walls and some internal areas of heterogeneous enhancement. There is some associated descending territorial herniation as the basal cisterns on the right side are effaced, and there is distortion of the brainstem structures. There is contralateral prominent temporal horn. And please go to the next slide. Characteristics are seen on the proximal images. There is some associated subfalcine herniation, compression of ipsilateral lateral ventricle. Contralateral ventricle is prominent. Same thing redemonstrated on sagittal images. Can you go back one slide? So in the left peri-insular region, there is a small, tiny enhancing nodule. I don't know it is artifactual or it is probably it is due to some, the pictures are captured, that is why, but there is another tiny nodule which I can appreciate in this. So please go ahead. The next slide. So this is hyper intense on T2 weighted images. There is significant vasogenic perilesional edema associated with lesion. And next slide. And the similar features of vasogenic edema are demonstrated on FLAIR coronal images. Do we have, I think we don't have the diffuse weighted images in this case.
No, Dr. Shumaila, yes, we don't have.
So my differentials are obviously number one is a high-grade neoplastic lesion, but we should see diffusion in this case to exclude the possibility of an abscess because there's a short history of 5 days. So keeping that in mind, my second differential would be an abscess. Less likely because there are internal areas of heterogeneous enhancement as well. But still, we should look for the diffusion and susceptibility weighted images to further confirm our diagnosis.
Okay, thank you. Dr. Shayan, what will be your differentials in this case?
Assalamu alaikum. I hope I'm audible.
Yes, you are, Dr. Shayan.
All right. So I agree with Dr. Shumaila's differential because we see a lot of vasogenic edema and there is a thick enhancing lesion, which is, though we see some disproportionate signals on FLAIR, which is kind of appear very bulky and does not look like vasogenic edema, but still we should keep in mind because in considering the short history of the patient, and I'm not sure whether the patient had fever or not, any signs of sepsis.
No, patient did not have any fever. Patient did have, kind of mild, I would say, confused state. And so that's it, but no history of fever. But vomiting, headaches, and a bit confusion also.
All right. So that's from my side. Thank you.
Okay, thank you. And you will call it the right temporal, or you think it is also going a little bit into like getting to the Sylvian fissure also, or it's below the Sylvian?
It's below the Sylvian fissure. It's though it's causing a mass effect and pushing it anteriorly and superiorly, but it's predominantly within the temporal lobe.
You?
Right. So he underwent neuronavigation guided right temporal craniotomy with maximum safe resection of the lesion. We got the post-op MRI done on
So
20.
just wanted to add something that the MRI was done within 72 hours, not 48 hours. And Dr. Shumaila, again, so your input is required.
I can see that most of the lesion is resected. There is just minimal enhancement along the medial aspect, which is, to me, I think there is maximum resection done. I can't appreciate a lot of tumor, only a tiny small, component along the medial aspect is visible. So since it is still within the 72 hours, I will call it, I think there is a small residual component left medially.
This one you mean?
Yes.
Okay.
Because it is following the same area which was of, the tube. Since we have seen the pre-op images, the medial wall was extending in this region. So it is probably a small residual to me. But obviously we will follow this patient radiologically.
Right. Dr. Shayan.
We have very limited images over here, very few axon images. And as compared to T1 weighted sequence, there is no intrinsic hyperintensity over there to suggest hemorrhage, post surgical hemorrhage. So probably this enhancement is definitely some residual tumor, which is, appearing bright. Had it been blood products, then it would have been bright on T1 as well. So that is favoring that. But apart from that, if you look at the flare images, we have a lot of residual signals on flare, which is suggestive of like probably the tumor infiltration over there, if it is a tumor. So we cannot really exclude a residual over here.
Okay. So the histopathology came out to be GFAP positive. K67 was low, IDH1 patchy positive, and they gave it like astrocytoma, IDH mutant, WHO grade 4. Now we can ask Dr. Adnan about his.
Yeah, so I mean it's a high grade glioma, and likely I agree with Shayan, there is residual disease. In high grade glioma, whether you have it or not, you do require post surgical concurrent chemoradiation. So this patient should get concurrent chemoradiation. There is data for IDH mutation. This is patchy positive, but that is only for low grade, not for high grade. So here you should just give concurrent chemoradiation followed by 6 months of temozolomide, monthly temozolomide.
Okay.
Actually, since there's progressive disease, I won't say 6 months, I would say until progression.
Okay, thank you. Dr. Mazhar?
Yeah, I would agree with Dr. Dan. Definitely, this patient needs chemoradiation, and with the radiation, you will start temozolomide and then continue oral temozolomide and assess the patient with follow-up scans.
Okay, and Dr. Mazhar, in your practice, do you see people getting PCV also, and these?
Yeah, yeah, in our institution, the conducted any studies as such because not many patients are on temozolomide. It's a small number of patients who can afford that. So we don't have sort of for comparison equal numbers. So it's hard to compare. But I personally believe temozolomide is better tolerated and is good for high grade tumors.
Right. Dr. Adnan, any input from your side? Like, do you see PCV versus temozolomide? Any experience?
So there is data for PCV for low grade oligos and astros. When you look at high grades, it's mostly temozolomide itself. But yes, in oligos, I'm talking about. So astros and oligos, you can. Excuse me. I certainly agree with Dr. Mazhar that if you get cytopenias with PCV, they are very long lasting because there's an early arrest in the maturation of your hematopoietic cells. It is much cheaper. It is a 6-week cycle, so it's lighter on the patient's pocket. But my personal preference is temozolomide, especially for the high grades. It's only in the oligos that I prefer PCV. But then again, I don't normally give PCV. I save it for the last when my patient has run out on all options when he has recurrent disease.